Okay, we're going to go ahead and get started. I think they're trying to figure out where our slides are. As many of you know, we can't really do a case panel without cases, so hopefully the slides will live here. I appreciate you all coming to this. This is a new panel for this conference, Stump the Experts. It can mean a lot of things to a lot of people. I think our experts weren't really sure what that was going to mean initially. I'm Meredith Holcomb. I'm the director of the Hearing Implant Program at the University of Miami. This is my friend and moderator, Dan Zeitler. He is at Virginia Mason University, right? Medical Center. So many things. I'm already getting it wrong. We have an amazing group of people on our expert panel, and I think as many of you know, after listening to a real-life superhero this morning, there's a lot that goes into cochlear implants and outcomes, and it truly takes different superheroes. You like that? Heroes? Yeah, with different talents to come together and to really be successful with leading these patients into this journey. So I want to just take a moment and introduce Tina Wong. She is from Minnesota. Charles Lim, who is at UCSF. Brenda Bliss, who is in private practice in Dallas, Texas. We've got Bill Shapiro at NYU, and then Jordan Holder, who's at Vanderbilt. So we have 2 surgeons. We have actually 3 audiologists, because Brenda is dual certified in audiology and speech, and then she also is a CERT AVT. So do we have the slides?
It appears
Well, I can answer that question right away.
Just bring it, guys. It'll be great.
Does anyone have a joke? Bill?
No, not that I can tell.
All right, well, give us a few minutes. I'm going to walk back.
Okay, any other questions?
So I'll tell you the way this layout's going to work, just so everybody understands it. We will have several cases, as many as we can get through, actually. The purpose is not to necessarily stump them or to make them be in a position where they feel like they don't know the answer or embarrassed by any reason. Of course not. We just want to bring cases that have been very difficult for Dan and I in our careers, and some that our colleagues out there have given to us as well. And we want to know from this group of individuals how they would manage these cases, what decisions they would make, what information they may need additionally that we're not providing. And if there's time after each case, we may have a minute or 2 for some of you guys to chime in. What? No, it's in the speaker ready room, the lady. Seriously? Okay, well, I have my computer. I don't know if that works. Okay, well. How many of you are audiologists? This is going to be great. All right, surgeons. Okay, SLPs, psychologists. Oh, I got my 2 in the back. Educators, researchers. Am I missing? Students. Oh my gosh. Yes. Am I missing anybody? Okay. So I'll just ask you guys while we're waiting for the wonderful cases to come up. Throughout your career, what would you say has been the biggest barrier to collaborating well with your team on cases that are difficult to manage?
You're asking us?
Yeah.
Well, I would say that it really is very important that you have good teamwork. That's always been difficult. When you're looking at a patient, it's not always that everyone says this patient is 100% a candidate. There are people that say, I might not go forward. So you do need a decider within the team, right? Because it's really not a major democracy. So I think just communication is can be very difficult, and it's important that you have it.
Mm-hmm. Anybody else? Go ahead, Tina.
I definitely agree with Bill. Having a team approach is important for both adults and pediatrics. I think pediatric cochlear implant programs do have like a monthly or bi-weekly or some kind of cochlear implant conference to talk about, especially the more challenging cases, but I think that's true even for the adult population.
Great.
Can I just-
Looks like our cases are coming, but
Oh,
I can
good.
ask you
So
more
I'll-
questions. Go ahead, Bill.
No, I'm good.
Well, I'm going to ask you one more follow-up question to that. Do you feel like doing more meetings by Zoom, especially with some of you clinics who maybe are more spread out, do you feel like the pandemic and the ability to do virtual meetings more often has allowed you to engage differently about complex cases?
I think Zoom, while there's definitely not awesome things about it, actually has helped collaboration to some sense, because you're right, those of us at different clinics can still find the time after work to meet without having to deal with traffic. And, I mean, yes, you can Zoom with your earbuds in while you're getting dinner ready, if that's what it takes.
And then one more question, Brenda, because I know you're not at a major medical center like the other four. How do you feel like your role as an SLP, how do you feel like your role has been implemented with the teams that you work with, the children that you have been serving your whole career? Do you feel, even though you're in private practice, that you're an active member of those teams? Do they engage you?
Yes, they definitely do engage me, and I'll do pre-implant evaluations and provide information to the surgeon and the team. And then when there are issues that come up, I'm in contact with the audiologist to work through different things. So it works well. I work with a variety of teams in the Dallas area.
That's great. So it sounds like collaboration is a big thing. So it seems like our IT folks have collaborated well with us. So we're going to move forward with this. We may stop and ask some of these little questions as we go. But I do want to say we had a little bit of a snafu as well. Amazon did not get this delivered to me in time today. But we were contemplating having our experts actually wear superhero capes. They were maybe going to be in the beginning, maybe at the end. But sadly, we don't have them here. So one thing that we just wanted to think about when you think about thinking styles on a team is how you think can change how your team is performing. And so this hierarchy of thinking styles is something that Dan had put in there. But a cult leader versus a learner, there's a big difference, right? So we're hoping that from this today, all of you can become better learners. And I know our experts certainly are that as well.
All right. Thank you to the folks in back for helping us. So let's get started without further ado. First case, 83-year-old male who is a farmer. He's had hearing loss for many years. His left, he reports a sudden loss about 50 years ago. At that time, no one was really doing intermittent panic therapy. He may or may not have gotten an MRI. Doesn't remember. He has used a hearing aid in his right ear, and he tried the hearing aid in his left ear for a little while, wore it off and on, but stopped about 10 years ago because he said it just didn't do anything. He does say he gets occasionally dizzy, hard to tell if it's lightheadedness or true vertigo, but he does get some dizziness, and he had a scan from his outside doc that was normal. You can see that there's a couple of family concerns. He came with two of his sons. One of them says that he thinks his dad has some memory issues, and as is true with many of the families that we see, the kids actually were kind of disagreeing because the other son thinks he doesn't have really memory issues, he's just lonely and can't hear. So I guess starting, we'll kind of just throw some softballs here to the folks at the end, Bill, Jordan. Does the length of deafness in the left ear, so this is a postlingually deaf person, does the length of deafness bother you as you start to consider which ear to implant? And what would you counsel this guy, if you do want to do the left ear, about his chances of a meaningful outcome?
I think the length of deafness in the left ear a few years ago would have bothered me a lot more than it does now. I think we're learning more and more that length of deafness doesn't affect you quite as much as we thought that it did, especially since it's postlingual. But given that both of his ears perform pretty poorly, I would probably implant the right ear. And if you did want to implant the left ear, I would counsel him that his results are probably less likely to be great, but probably not the same counsel we would have provided even 5
So, Bill, I see you nodding your head.
Well, I mean, this is an expectations conversation, right? If we think he's going to do better in his right ear, but what happens if he doesn't like it? He probably won't do as well in his left ear. I mean, it wouldn't be unheard of to talk about both ears. You know, you can do this under there are surgeons that do this under local anesthesia. That's a possibility, but you know, it really depends on what he wants. He won't do as well in the left ear. What happens if he doesn't? Then he may not want to go ahead and do the right ear. So that's a thing that's something we have to talk about as well. And then we really have to figure out what his expectations are. What does he want to be able to do? If he wants to be able to hear on the phone in that left ear, it's going to be tough.
Do you think someone like this would be satisfied with sound awareness in the left ear before you did the right ear? Because the risk obviously here is you implant the right ear and now he's got no acoustic hearing.
Right. I don't know the patient, so it's hard to know what he'd be satisfied.
Well, that's why we're stumping you.
That's not stumping me. That's not really a stumping kind of question. So it's hard. It's difficult to know. I'd have to have the patient in front of me and really ascertain what his expectations would be.
What would be yours?
In the right ear,
Yes.
if we implanted his right ear, I think you should have. I don't do numbers. There are some people on our team that do numbers. I don't do numbers. I say, I think you're going to be a significantly better communicator with a cochlear implant in your right ear.
Okay. Brenda, in an adult, and I know you do many, many more children than in adults, but is this someone that you would want to see preoperatively? Do you think there's added value to helping Bill have that expectations conversation with someone like this who is deciding between risking an only hearing ear versus potentially not getting a great outcome in a non-hearing ear?
I think it would, oh, that's loud. I think it would be good to do an assessment pre-implant to see what his motivation is, to see what family support he has, to see what his skills are like with his hearing aid in the right ear, and just to provide some input on those areas.
I'm just going to add too, I think you say only hearing ear, but right now he's already writing to communicate, so I'm not super concerned about potentially sacrificing that residual hearing.
Sure. Charles and Tina, so how do you have a conversation with this gentleman? Hearing preservation in that right ear, possible, not possible, realistic, using acoustic electric stimulation, sort of an 83-year-old with maybe memory problems?
Yeah. Thanks, Nathan. I mean, this is sort of a classic situation where it's not just about, I think, expectation setting, but really quality of life analysis. And I think if you kind of take a patient like this and you really do kind of a holistic assessment of whether they can exist as they are versus taking let's just say, some degree of risk that they'll lose whatever acoustic hearing. Of course, when we do surgery, we always try to do hearing preservation. And ear like this is pretty damaged anyway, but I think the biology of this ear is not healthy. So even if you can preserve those acoustic frequencies, it's probable that through fibrosis and osteogenesis over the ensuing 2 to 3 years, you probably lose those low frequencies anyway. So if I'm going to implant this patient on the right side, I'm going to hope that ultimately the electrical hearing they get on that right ear is enough to restore them to a reasonable quality of life, and then also hope that they get a certain amount of acoustic preservation. But I really do think that, similar to what Jordan said, I mean, if this patient is struggling right now, being overly fearful about losing, the 250 hertz hearing is probably, in the end, not going to serve that patient that well. He's not getting younger. He's already 83 years old.
Sure. And Tina, to switch gears a little bit, dizziness, so would you do a VNG on this gentleman and risk the possibility of giving him, let's say he had a labyrinthitis in that left ear and now you're risking bilateral vestibular dysfunction, number one. Number two, does the memory thing bother you? Would you have someone like this formally tested? Do you do a mini mental status or MOCA or something in your clinic? So talk about those two medical issues.
So as far as vestibular function, I actually posted something like this on our Doc Matters board because I had a patient, elderly, who did in fact have dizziness. I did the VNG, and interestingly, his better vestibular ear was his worst hearing ear and was the ear that we were thinking about implanting. And I put that out onto the forum, and I got a lot of response
that most surgeons were really not that concerned, because we are doing a fairly good job of hearing preservation, and that we probably do an even better job of vestibular preservation with implantation, so that maybe was not as much of a concern. It really depends on sort of how dizzy he is as far as whether I would do any kind of testing. And the memory issues, that's good, so if he has Medicare, he's gonna have to do health psych anyway. So that's, that's a given. And but even if he didn't, that might be something to think about. Again, not just because of where is he cognitively, but as other people have talked about, what is his social support? Because, that last line where the son says dad is lonely, I think that's gonna be huge as far as counseling the patients, because if this is an 83-year-old guy that lives alone on his farm with nobody that comes to visit him, who's he going to talk to? Where is he going to get that auditory stimulation? And I think that's really, really, honestly, the most critical thing about how he's going to do it.
Sure. And Brenda, do you engage the sons to help? So how do you send this guy away after his implant with his two sons who are clearly involved in their dad's health and care and loneliness? Do they participate in his, auditory training at home? Is it online? Is it in person? Sort of how do you engage everybody?
Ideally, they would all work with him, but I'm wondering also about the memory issues and the fact that he's lonely could be partly due to the hearing loss. He's not getting enough information, so he may not have memory issues. They may be related to not hearing consistently. I just was thinking of that. But as far as working with him, yes, definitely getting them involved and giving him resources online for if he can access them from the different manufacturers, different types of auditory skills work and working with the sons.
Great.
So I have a question for the audience. So how many of you would be counseling a little bit, I guess, more conservatively and suggesting doing the left ear first?
Show of hands.
Show of hands. Okay. And so the majority of you would be counseling for the right ear. Let me ask all of you this as a panel.
One more question, hold on. How many would do simultaneous bilateral, assuming insurance wasn't an issue?
Yeah, I would do that too. So one final question, would it make a difference, would any of you change your approach to left ear versus right ear first if you had more information with the 125 hertz? Let's say 125 hertz was more closer to normal or in the mild range, and so he really was using that little bit of low frequency information for safety reasons living alone. Would that change your approach or your counseling? Any of you? No? Okay.
I have another question. If he wasn't a farmer, would that change anything?
No.
Do you want to know what kind of farmer he is? Because I can tell you that. Would that change?
He's a dairy farmer.
No.
Well,
Apples.
And the reason I ask that is that many of us see these patients and they have that tiny little bit of hearing at one frequency, right? And they're holding on to it, and sometimes it's a little more difficult. But yeah, he could be a farmer, dairy farmer, beef farmer.
Meredith, to your point,
Like Dwight Schrute.
Meredith, to your point, I think that's super variable across patients. So just asking them how much they rely on it. You can easily get a patient like that says they can't hear anything, or you could get a patient that says, oh no, I don't want to lose it, I rely on it at night, in those different types of situations.
Okay, so what if it's the same audiogram but a different story? So a 60-year-old female, history of bilateral otosclerosis, had a right ear stapedectomy years ago with reportedly improved audable hearing at one point. But the hearing loss has progressed. She has used hearing aids bilaterally over 20 years with declining noticeable benefit. You can see the CT scan results there, and of course the speech perception testing is the same as before. So let's start with any of you. Would you be thinking about a specific implant or electrode for this case?
Before we did that, I would ask the surgeon if they needed any more type of imaging.
Yeah.
I don't know the answer
that's
to
a great
that.
question.
I would ask the surgeon that.
Okay.
What would be the answer?
There's your imaging
Oh,
extra.
so I'm stumped or you're stumped?
Oh, well, I'm stumped because I can't read it, so.
I'm not sure if her state-use prosthesis is gonna allow you to do it.
Okay. So would you be thinking about it? Yeah.
If she had an MRI, if she had a compatible implant, would you want something else? I'd be okay with that.
Okay. So would there be a specific implant or electrode that you would want to use in this case with the history of otosclerosis? And would you be willing to comment on that?
I would probably use it for wrist as well, because it's direct, and so I can get through any sort of those spongitic changes in the cochlea. A lot of times if I hit some resistance, I don't even take the stomach off.
From my perspective, if that's the cochlear we're trying to implant, I don't think that there's anything on imaging that would lead me to select a certain company, meaning I'd be okay allowing the patient to choose their manufacturer. I might have some preferences on electrodes, but based on the luminance there in basal turn, I think it's really, it seems that if there were an MRI signal that showed a nice occlusive, I'd be more reassured. I feel like I could get most electrodes in that area.
Okay.
So you actually answered the question I was going to ask, which is, we all know sometimes the CT can underestimate luminal obstruction. So I think to Bill's question, which was a good one, MRI is certainly something that can be well argued here because it may give you some additional information about the fluid signal in that cochlear lumen that may change. But I agree, based on what we see, there certainly doesn't look like any obstruction.
And I think one option is to tell the patient, go ahead and choose an electrode, go ahead and choose a manufacturer, and I will try, but I will have a 612 in the room as a backup.
Can I just add something?
Of course.
So it says that this patient's wearing hearing aids in both of her ears.
Yep.
So then I would have a conversation with her about bimodal hearing and cochlear implants and how different implant companies deal with a contralateral implant.
So you feel like thinking about that patient holistically, you may be more inclined to recommend or lead them down the path of one company versus the other?
I would explain to them
Yeah.
there are differences.
Yeah, perfect. And then let me ask you this, Bill. So with this new history compared to the last case that we talked about, and with the otosclerosis and everything that's involved now, would it change your mind about which ear you as the audiologist would want to implant, given the higher risk of facial nerve stimulation?
No, I think facial nerve stimulation can be dealt with.
Okay. Jordan, anything?
I agree. I'd want to go forward with implanting both ears, especially considering her age.
Yeah. Perfect. Brenda, let me ask you this, and this, especially with you seeing so many children, and I know you see a lot of children who have multiple involvements other than just hearing loss. I would suspect that you've seen some kids who have had facial nerve stimulation, and maybe you've noticed it even during your speech sessions. Is that something that you're able to report back to the audiologist and do some co-management, co-treatment?
Yes, maybe like eye blinks and little twitching, and I will watch it a few times, a few sessions, and then report it or have them report it. So I have seen that.
Do you feel that most audiologists are receptive to your report back and engage enough with you and with the patient to want to make some of those programming changes?
They are.
Good.
Yeah.
Good. Do you feel like that's changed over the years?
I don't know. It's been. I mean, I've had a good relationship with them, so I can't think. I've always been involved in that way, so I'm not sure if it's changed, but it's always been important.
That's good. And then just a question to my audiologists out there. How many of you are actively co-treating with your speech-language pathologist? That's amazing. I think that's a difference of what we have seen in the past. Okay, good. So we're going to move on to case 3. So this is a little boy that is near and dear to my heart, actually. So he came to our clinic when he was 6 years old. He was referred for a second opinion for hearing loss based off of his speech and language delays and the fact that he was in speech therapy and his speech and language was not improving even with the use of hearing aids. He was fit with hearing aids when he was 3 and was not ID'd with hearing loss until he was 3 either. Oral communicator, talks all the time, incessantly talks the entire appointment. But we don't know very much about his birth history. So in Miami, we see a lot of international patients, and this family had traveled from the Cayman Islands to our clinic. He now lives with his father, the father's girlfriend, and his siblings. And his dad became the custodian or the primary parent at age 3 years old. So really didn't know a whole lot about any of his history before then. Seems to have behavior problems, has been held back in kindergarten, and recently was transitioned to a school for children with behavior problems. So this is his hearing tests that we were able to do the first day we saw him. And you can see that he has a moderate to profound hearing loss in the left ear and then a profound hearing loss in the right ear. We use condition play even though he was 6 because he's so hyperactive. It was the way to keep him engaged. Really great little tester. We did use new chips at the time, and some of it was because we were trying to get through all of the testing in one appointment. Also, some of it was because his articulation was so poor on some words that it was difficult to understand him. Everything else seemed to be pretty much in line with what you would expect from the from the unaided audiogram. His imaging was read as unremarkable, and it was an MRI scan.
You use news chips as a closed set test or as an open set test?
It was a closed set test, so he was pointing to pictures. So to Bill and Jordan, just based off of this, so he was unaided for 3 years and then has been wearing hearing aids now for 3 years. So would you have any concerns going into this with solely this information about the congenital deafness in the right ear and moving forward with a cochlear implant in that side? Or what would your thought be about proceeding with that cochlear implant consultation? Or is there anything else you'd want to know?
I can't not mention that for sure we want to use record instantly
Yeah?
instead of monitored live voice.
Yeah.
I think a monitored live voice using new chips as opposed to closed set task really gives me no information about his understanding ability in the left ear. So that would be the first thing that I would want to add.
Okay.
But you wouldn't be thinking, would you be thinking about, you'd be thinking about planting the right if you would do anything, no?
Yeah, but I want to know for sure.
No, I get it.
Yeah, I think the right ear certainly first and then assess potentially a bimodal condition afterward.
Don't let him bully you. Don't let him bully you.
What?
Let him bully you.
He says you're being a bully.
I was just asking.
I'd be considering both from the get-go,
Okay.
especially considering the speech and language delays that are still occurring.
How many of you out there would be considering the right ear only at this point? Left ear only? Both ears? Both ears simultaneous? Okay. So surgically, scans look good, everything looks okay for you guys. What kind of conversation would you be having just based off of this information with the family, not knowing anything else? Is there anything else you would want to know from a surgical side? And maybe there's not.
No, I mean, I can't see anything that's particularly unique about the situation yet. Certainly, I mean, the standard things about a rambunctious boy and the process of if we're going to stage the procedures, we need to do one and then second down the road, what that might mean in terms of, all the usual things that we worry about.
Right.
I guess, did you say that we had some imaging towards?
Imaging's unremarkable. That was the constant, yeah.
So I'll ask a question as a surgeon to the surgeons. How many times out of 10 does someone like this come back for their second ear once they've had one ear done? So one of the things that we deal with, obviously, and if done with some questionable past health history is how reliable they're going to be, right? So does any of that past history sway your decision as to sort of put all your chips in at the beginning versus hold some back?
I can imagine a situation where it would, but I don't think from what I've heard yet, we're in that situation. There's some families and situations where it's essentially a disaster, and you're sort of like, you're trying to salvage whatever you can, and the hope for long-term follow-up is not so good. But that also raises other issues with whether or not going all in and doing 2 implants is actually also setting the child up for more problems. You know, I mean, there's more risk of difficulties arising with more intervention as well.
Brenda, I'm going to, then to Bill. Brenda, for a case like this, and you see the child, and clearly they are using, getting some good usability out of the hearing aid, at least for the left ear. What is your plan? What else do you want to see to help you make that decision with the team?
So I'd want to see the aided audiogram, and also see what their auditory skills are like. Is it up there? Oh, it's up there.
Yeah,
See,
just
I don't
put it
see
up
it.
there.
Oh, thank you. Yes, that would be important for me. I'd also like to assess their auditory skills and see what those are like. And I'd want to know where their speech and language skills are. I'm thinking, for me, it would be nice to do which one's the right ear first, because that's the poor ear, right? I can't tell. Okay, nice. And see how they do, and then based on that, probably do the second ear, but I doubt they get enough from the left ear. What else? A lot of the adults that I see will say they're not going to get a second implant, and they get the first one, and then inevitably they get the second.
Bill, were you going to say something?
No, I think that slide, I think that Jordan had a good question in the beginning, was we don't know enough about that left ear hearing aid, and this is telling us that things are set okay.
Yeah, so, set to DSL targets, speech intelligibility index is a 0.51. So, Jordan, now we've incorporated recorded speech. Of course, we didn't just go off of the monitored live voice. We brought him back the next day for round 2 of testing. So, looking at these results, what would be your plan?
A couple of slides ago, did you say that they had progressive?
That's what, yeah, I mean, this is the thing. We didn't let them review. So we don't know, right? I mean, he came to us at age 6. Dad got him at age 3. I'll tell you, in the appointments, Dad really said nothing to us. Dad's girlfriend was the one who served as historian. So there's definitely some complex family issues there. We don't really know. Dad just said, yeah, he thinks it had progressed.
Tell us why you asked the question.
Because if it was progressive, then I might feel better about that right ear. If he had had that hearing loss from birth in the right ear at this age, then I'd be a little more concerned about his outcomes. I think normally I'd be a little more gung-ho to go forward with bilateral simultaneous for this type of child, but given that he lives in the Cayman Islands, I'm not sure what his access to equipment is going to be like. I worry if we go bilateral and he doesn't have access to his equipment, and we take away some of that left-sided hearing, that could put him in a potentially worse position compared to someone who might live in Nashville near our clinic. So that would definitely be a consideration in my mind.
So does it concern any of you all that he's fit appropriately with hearing aids in both ears, and that he still exhibits all of those speech and language delays and articulation errors that likely will not change drastically with one implant? Quickly, change.
Well, I don't know, did you say he just didn't get aided till he was 3?
Till he was 3.
Okay, so you have to look at him like a 3-year-old child.
Exactly.
So 3 years hearing aids, and that is if he's wearing his hearing aids all the time.
10 hours a day.
Oh, he is. Okay, sorry, I missed that.
Loves them.
Oh, that's good. Since 3. Okay, so, you would have to look at what would you expect a 3-year-old to be doing. I don't know, is he severe expressive delay and...
Significant receptive delay. He uses the K sound for S, the G sound for Z, and the K sound for sh.
Okay. What kind of therapy is he getting?
He's getting auditory verbal therapy in the Caymans.
Okay.
And he also is getting therapy at school.
Okay. And severe expressive and receptive delays compared to a 6-year-old or compared to a 3-year-old?
That's a good question. This is as much as we know.
Okay.
Yeah. So at this point, how many of you would be implanting just the right ear? Just the left ear? Both ears? Simultaneous? Okay. So we're a little crazy. I think my student who was with me at the time thought I was real crazy, but I confidently said I want to do both ears simultaneous. And part of the reason is he is living in the Caymans, and we don't know about follow-up, and we don't know about barriers to getting back to the clinic. And so we made a decision and, prayed a lot and crossed our fingers. Dr. Hoffer did a wonderful job with his case. This is his post-op audio. It looked exactly the same. Exactly the same. These are his post-op scores 3 months later. So the right ear, you can see, is actually, and I didn't put this on here, but his right CI is actually now performing very similarly to what his left hearing aid was performing.
What device did he get?
He got a 632, both sides. They stayed in Miami for about 2 weeks. We did the activation a few days later. We saw him 3 different times for programming before he went back. And he had a beautiful audiogram in both ears by the time he went back. Was consistently wearing the devices. The parents had really done a good job of counseling him about what it was going to be like to, not hear for just a few days before we activated him. But that brings up another comment I wanted to ask you guys, or a question. How many of you have a psychologist on your team? Child psychologist. Do you have anyone for a family situation like this? Would you explore any other individuals to include in this case to try to work with the family or the child about how difficult it may be for a few days of not hearing, or try to look at a bigger picture of the ADHD, ADD? Anybody?
Well, I'm just going to say it might not be ADHD. It might be the hearing deprivation and not really being at where he is age level and being able to communicate with other kids his age. I don't know. It may not have ADHD. It may just be the hearing related, potentially.
So let me ask another question. I'm going to put this to Jordan and to Bill. So you see his post-op audio is there. At 3 months, here are his speech scores. Would you be interested in trying an EAS device? Yes.
Jordan says yes.
Okay. Obviously, I'm assuming just the left ear. Yes.
Yes.
The reason I ask that is because we don't have 125 hertz there. So would that change anything if for some reason you had a 125 hertz threshold better than 70 in the right side? No. Okay. And would it change your recommendation for EAS, knowing that he's going to be going back to the Caymans, and similar to what Charles was mentioning, you never know, and Dan said you never know if they're going to come back. Does that change your thought process for this specific case with management of the equipment, troubleshooting?
I think I would for sure just give them a fully electric program in slot number 2 to make sure if and when their acoustic component breaks, they have an alternate backup to go to that gives them the full frequency bandwidth electrically.
And to the two of you, can you talk about your experience with hearing preservation in kids specifically? Do you do anything different? Do you give steroids? What are your sort of gestalt feelings about rates of preservation in kids versus adults?
Well, we do have kids who are wearing hearing aids for low frequencies. Often they don't maintain their hearing for a very long time. We also have patients who maintain their hearing and don't want to wear an acoustic portion. That happens an awful lot, especially with adults. So.
Yeah, at least for us, our pediatric versus adult protocol for hearing preservation is the same. Everybody gets steroids in the perioperative period and soft
that brings up another issue that we have a lot, which is even adults who have maintained hearing, they come in, they lost it, they may not have known they lost it, how long ago did they lose it, and what do we do? So we'll typically reach out to the otologist, who may or may not put them on steroids, but I think after a while, it's like they'd be on steroids all the time.
Yeah.
So I think that's what our otologists say, it's after a while, you just can't do it anymore. Is that what you guys think, feel?
Yeah, one of the sad truths is that we have no approved medications for hearing loss, and we use steroids for so many different diagnoses in the ear and trachea bone. It's really kind of a shame because it just tells you the lack of specificity we have in our approach towards inflammation. But yeah, there's a limit to how much and how long you can put somebody on steroids for, but certainly acute surgical adjuncts, I think, very useful.
And then one other question that we didn't talk about is the educational setting, right? So Bill, I know you have a lot of international patients that come to NYU. How engaged is your team with that child's educational, setting, or their teachers, or does tell me how you collaborate with them?
Right, so we have an educational coordinator who is great, and so she deals with it. And that's one thing about our team, I don't get involved in that, I just make sure she knows to deal with it, and she does. So that's my answer to the educator. And I think that's fine, I think that's okay.
Perfect. Okay, great. So Dan's going to do the next case.
All right, the dreaded cochlear implant evaluation audiogram. This is a 35-year-old male. He works in construction, but he happens to be a rock and roll musician, has played the bass guitar for many, many years. He has a long noise exposure history, obviously, from his work. Sometimes does and sometimes doesn't wear hearing protection. He also has a CT scan that was normal, and we did get some of his prior audiograms that show a pretty clear and obvious progressive hearing loss over the past 10 years at least. There's no family history of hearing loss. He has used hearing aids intermittently. Obviously, he finds it very difficult to use them on the job site, but he has been using them fairly regularly for the last 4 years. He really relies mostly on lip reading and struggles tremendously on the phone. And for this particular case, I want to just make sure that you're all seeing the speech scores in the lower left corner there, because this is a gentleman who needed quite a bit of noise to qualify. So I guess Bill and Jordan, thoughts on qualification in so much noise, lots of data out there that is up for interpretation, so just your thoughts here initially.
Yeah, I think this patient's a candidate for an implant on one side to begin with. The surgeons do a great job in preserving hearing, and maybe we can obviously give them an electroacoustic stimulation. So yeah, he's not getting much synergy from both ears together in terms of the AZ Bio or even the AZ Bio in noise, so I don't know that he has that much to lose. So,
Jordan?
Yeah, that last comment was going to be my perspective exactly, that even if we implant one ear, he's getting about the same benefit from one ear that he would from two. So I agree move forward with implanting whichever he felt like was his worst hearing ear.
Is the protocol there in the lower left corner what you use at your two centers respectively? Okay, and Charles and Tina, +5 and quiet?
We would usually do 10, so 5 is a lot, as you said.
It's a good thing he's a bass player.
That's a good.
Bill, were you about to say something?
Yeah, I think what you do is give them enough noise to make them.
So that was my next question. So what you're basically saying, it sounded...
This patient needs to have a cochlear implant.
Right. Anybody can be a cochlear implant candidate if they're standing on the runway behind a jet, right?
Right, so this guy should get a cochlear implant.
So that's my follow-up question then. Should we be using CNC words really as our qualification test and then the AZ Bio just to get insurance authorization?
I think the bottom line here is that we shouldn't be using any certain number to qualify a patient. In my opinion, where you have doctoral level profession, we should be able to assess the patient as a whole, decide if they can get the device covered in some means or another, and decide if they're going to do better with an implant than they are currently. And if we can say yes to both of those questions, then we should be proceeding with an implant.
So, assuming that you're not going to use a number, what is your number on CNC? So at what point on the CNC test do you say, this person is a candidate, having heard all of the other story, of course, and then going on to using noise? 60, 40, 50?
I think this requires a team approach to talk to each professional, have them evaluate the patient and get a feel for how they're doing, get an understanding of what the patient's expecting. So I don't think it's about the numbers just for insurance, in my opinion.
Okay.
I agree. I mean, I could throw out a number too, but I think that number would be different if some of these variables on the right-hand side were different. If, you know, the idea of using +5 is not just so that we can qualify anyone, but it's so that we can qualify anyone that we think would benefit from a cochlear implant.
He's a candidate.
So, you know, if they were 97 and had this hearing loss, it would be a different conversation. So I think leaving it up to the professionals without a hard number is really what this field needs to move forward.
Just a show of hands in the crowd, who uses +8 noise? And what about +5? Okay. Something. What are you? Why are you
Oh, I
iffy?
said this
Why are you
because
ishing?
it's sort of like Jordan said, it depends, right? So for our kids who are progressively losing hearing or maybe just not performing well with hearing aids, and we know an implant's going to be better, yeah, you put a +5 in there, and you might have to even go down to 0, but those kids probably on the CNC word score are going to be missing a lot, right? They're smart, they can put things together. This guy who's 35, compared to the 97-year-old, depending on who the 97-year-old is, you know, he may be using a lot more acoustic cues to really put together the sentences, and but the CNC words, for me, that's like alarming because 40 and 52%, I feel like he has a better chance of performing better with a cochlear implant.
Sure.
So it's not cut and dry, it's really patient specific.
Okay. Tina and Charles, electrode choice, are either of you still using short electrodes? And if yes, and if no, do you have a preferred electrode here? Do you try to use something shorter?
Would you like a specific electrode for this?
You know, this might be my general philosophy, but I tend not to try to steer towards any manufacturer unless there's a really compelling reason to do so. In this particular situation, I can't actually, like, if this patient told me they wanted to go with any particular manufacturer, I think that would be fine. And I think electrode-wise, like normal CT scan, this kind of audiogram, you want to do some technique no matter what. I probably wouldn't choose like the 612. I'd choose that softer, smaller electrode. But beyond that.
And Tina, you also shook your head for a short electrode. Can you expand about why you both adamantly shook your heads?
Well, I think when we think short, we think hybrid short, versus, let's say, the Med L24, which is shorter, and that might be an appropriate choice for him, because he does have that good low frequency hearing. At our institution as well, we let the patients choose, because they choose more based on all the bells and whistles of the processor. And so I think as long as you're following that soft technique, your results for hearing preservation are probably not that different between the different manufacturers.
Just to be clear, my thoughts on it's like a hybrid electrode. It's based on not sort of the first year or two of use. I mean, that person should do really well initially. But construction worker, 35 years old, and a musician, the risk factors for ongoing noise loss, and just the rapidity of where he is at 35 would suggest that 5 to 10 years from now, you will wish he had a lot of.
So good point. So anybody on the panel, does the progressive loss, how would you counsel the patient about his chances of hearing preservation, both short and long term, given his very demonstrable progression over the last 10 years?
I think the progressive hearing loss really pushes you to say sooner rather than later. You know, I think most people here agree he is already a cochlear implant candidate, but if he's wavering because he's afraid that he's going to lose the hearing that he has, I think that's just another argument for saying you're losing your hearing pretty quickly, and honestly,
And
I
please,
think you
Bill.
also have to look at his high frequency loss and look at his, how long his high frequency loss has been that way, because that's also a counseling issue. You can get someone with a really long-term high frequency loss who may not do as well with the cochlear implant. Not that you shouldn't implant them, but that's, I think, a counseling issue.
Tell me more.
Well, if a patient has not been stimulated in the high frequencies for 40 years, I think it may be more difficult for them to get a higher score on a cochlear implant, and I think you need to talk to them about that.
Sure.
I want to follow up with that, Bill. Are there specific complaints that you hear from those patients after you activate them and are programming them? Are there consistent complaints that they have with sound quality with the implant that may impact their performance?
Nothing,
okay.
Not necessarily.
And a question for Brenda and Charles. Charles, we know you're much into the music appreciation. Music therapy for this guy, what is he going to think about music after his implant? Is going to be less happy or more happy? And is there anything to do to help him?
So I can try to answer that. I think music therapy as kind of the standard way we think of what music therapy is it's not really right for this patient. Now, that's different than a conversation about musical expectations, especially as a musician. And so my thinking here, you want to preserve one ear's low frequencies. And I think for musical perception, pitch accuracy in particular, you need to have low frequency acoustic information at accurate pitch. It's almost impossible for a cochlear implant to give you accurate pitch. And so if music's actually important to this person, I would never advise bilateral implantation early, even if the hearing loss are aggressive. I think that the problems with music and cochlear implants are many. I mean, I don't think we need to get into it. So, but I think that if I had to boil it down to one problem, it's that it's out of tune. And the reason it's out of tune is not just because the fundamental frequency is not aligned properly, but also because the harmonics are not aligned to the fundamental frequency for a given complex pitch. And so I think you have to explain to a sophisticated musician that there are going to be issues, that the device is really intended for speech, and we're using it for this harder, more sophisticated signal of music with the idea that there's going to be an impoverished nature to both pitch mapping. It's going to be fuzzy pitch, inaccurate pitch, and then also the timbre is going to be off. But the combination of a hearing aid and a cochlear implant, this patient's still probably going to do better musically than they're doing without either one like that.
Does a longer electrode, so if you sacrifice hearing preservation for length to get a better pitch place match, is that something you have a talk about with this guy as well?
So in an ideal world, I think the more input you can get, the better. That still doesn't address the issue of tuning in that critical part of the cochlea, but there's a certain benefit to thinking that you can get as low down as you can get to. Now, that doesn't mean that the testing and the data are not really there to strongly show yet that you should always put the longest possible electrode in a musician, for example. That kind of sort of simple statement, I think you would think it would be easy to prove something like that, but it's just not. And we've had plenty of patients that have a standard CI electrode that really perform better with music than you might think. And I think the musical brain has a lot more to do with it than the electrode that's chosen.
So to your point, Jordan, Brenda, and Bill, anything you do with this patient, either programming-wise or post-op therapy-wise, to help with music?
No, I would just reiterate that we have a lot of patients, I think, with longer-term high-frequency losses. Tom, I don't know if you want to comment on that, because we talk about this all the time. When someone has a long-term high-frequency loss that looks like that, and that involves real counseling, I think.
We'll have to add you to the slide of experts now.
No, I'm not an expert.
We don't have enough capes, though.
I'm not on. Am I on now? Okay. So yeah, what I learned from the Hybrid L study, we focused all on low frequencies when we counsel these patients, but take a good look at their highs. And if it's a dead ear versus a profound hearing loss, if they don't have thresholds, and you're off the audiometer, that's a dead ear, and it's been long duration, they may not even have neural elements, so what's the point of putting a short electrode only in the high frequency regions? Even your first two patients had a dead ear, almost, maybe a corner audiogram, I'm not sure. Sometimes that can be vibration and not hearing. So it is important to look at the highs, and then that helps you determine electrode length. So a dead ear in the high frequencies needs a long electrode, in my mind, or they're not going to do well. And we do have patients, like Bill said, that have dead ears for a long period of time in the highs, and you think they do well, and they don't do well. And so that's my comment. Thanks.
Great, thanks. I guess, Tom, follow-up. Have you had to take out shorter electrodes to put in longer electrodes simply for that reason?
Yeah.
Yep. We have a couple of minutes left. I can just give you some follow-up. So this was the post-op audiogram. We went ahead with this guy's right ear. This was his post-op audiogram. He did fantastic. Comes in at 6 months to have his programming and testing. He kept telling the audiologist he felt like there was wax in his ear, but she looked and there was nothing. Didn't do any specific audiogram. Then he comes in for a year testing, and that's his audiogram. And he never felt, other than this whole 6 month, I think I have wax thing. Clearly we were talking about the fibrosis issue and sort of you can't bank on EAS and hearing preservation. This was a perfect example. But the good news is he continues to be a fantastic performer, way better than he would have been with his acoustic hearing with CNCs in the 30s and 40s. So,
And still playing music.
still playing music. Not thrilled about it, but certainly happier. In the last couple minutes, I guess we have another case, but I'd rather probably open it up to any. But I don't think we'll have enough time to do. So why don't we just take any questions or comments about any of these 4 cases, or if you have something with a personal patient of yours that you can borrow the brain power up here. Happy to take questions. Otherwise, we'll donate $1.30 back into your accounts.
So I have a specific question about this patient. When they first came in for programming, my assumption is you had them maybe on an EAS programming. At what point was it EAS or was there overlap? And I'm assuming you took it out when you repeated the audiogram. Did they adjust it at all in between based on patient perception?
Yeah, so why don't we have our audiologist, let's pretend this is one of your cases and say what you would do here. So question 1, would you overlap?
Would you
And
overlap?
question 2, what would you do with the 1-year audiogram now?
I think we would give the patient 2 different possibilities and let them try it. In other words, fully electric and not overlap, but I call it kissing.
I agree. Always giving
Gross.
a full electric.
Sorry.
I think always giving a full electric program and then a second slot is a really good idea, especially with the RIC acoustic components. I myself doing that regardless, even if I think their hearing is going to maintain.
So if I can ask you, what's your background?
Programming adult
So
audiologist.
what would you do here?
I would probably do an overlap.
Because?
To be honest, I've only had one patient that I put a lot of EAS on and a couple of ones that I tried it on, and I did an overlap and I took it away and they didn't notice a difference. So I've only had one that ever maintained it.
Yeah, it's interesting, and I'd love to hear comments. We talk to all of our patients about the possibility of EAS postoperatively that have hearing, and so few of them actually end up using it and using it consistently that it's kind of developed this vicious negative feedback loop in our clinic. The time it takes to counsel and do it all versus the number of people that actually continue to use it. So we've had not super great outcomes. Yeah, Fred.
Terrific panel. I know this is a cochlear implant meeting, so perhaps this is a heretical question, but how about a frequency transposition hearing aid prior to cochlear implantation consideration? Or bimodal with one of those and a cochlear implant on one side.
Bueller.
Not good for music, I will say that.
Say it again, Charles.
Yeah, frequency lowering aids are not good for music at all. And so at least from that perspective of this person's life, that would be counterproductive.
And I think one thing we haven't really touched on is the whole quality of life component, right? And so it would be interesting to know with quality of life questionnaires, and their expectations, what do they want to get out of hearing better? So for some people, maybe a hearing aid option is sufficient for them, but for many folks, especially musicians, they likely want to get back to where they were when the hearing was better. And hearing aids, unfortunately, are going to just sort of move all of that high-frequency information over. Or you potentially are amplifying dead regions, which is a disaster too, yeah. Bill, would you do anything different? You're a hearing aid expert? No? Okay.
So we do have a couple of panelists that have to get to our next thing, so if you have a quick comment or question.
Very quick question.
Yes.
I'm wondering if there were fluctuations in electropieces on the right ear with the loss of hearing, because when I was in Iowa, many of our hybrid L patients who had sudden losses in hearing had impedance fluctuations.
I don't know the answer to that, but we see it. I don't know about this particular patient, but we also see it all the time. Fibrosis and other intracochlear. Well, on behalf of my co-host and these wonderfully intelligent panelists, thank you very much for coming, and enjoy the rest of the meeting.